Good afternoon, and thank you for joining us today as the National Board of Public Health Examiners presents the fourth in our series of 6 webinars geared to explaining the domain areas of public health to help you prepare for the upcoming Certified in Public Health CPH examination. Each study session will be led by an expert faculty from ASPPH member schools and will focus on one of the 5 core areas of public health. Each session will be 2 to 3 hours long and will include a presentation, lecture, and interactive segments. A break will be offered midway through the presentation. This presentation will be recorded and archived on the MBPHE website 1 to 2 days afterwards. You may register for the remaining session on biostatistics on the MBPHE website. Unfortunately, the environmental health webinar is being rescheduled, so please refer to the MBPHE website in order to find the new scheduled date. Today's session feature is health policy and management. Please feel free to key in your questions in the bottom right-hand corner of your screen, and we will answer at the end of each segment. We are pleased today to have Joel Lee, John A. Drew Professor of Healthcare Administration and Director, Doctor of Public Health Degree Program at the University of Georgia College of Public Health. Joel, you can begin.
Great, thank you, Kate. Hello to those who've joined us. It's my pleasure to make this presentation. I have a good deal of information, and as Kate mentioned, I'll welcome questions as we proceed. Let's make sure I have control of the screen. I believe I do. So let's go ahead and get started. You know, it's like one of the things that interests me, I have both an MPH and a DRPH degree, is how people perceive public health. And rather than what I do in management and policy, people think much more about events in public health. The movie Contagion is an example. Don't talk to anyone, don't touch anyone. I think there are a lot of perceptions. Just for fun, I wanted to share you 2 little slides I have. How people think about public health. What my parents think I do, what my friends think I do, what my kids think I do, what society thinks I do, what I thought I'd be doing, and what I actually do. And here's the second one. Again, what my friends think I do, what my mother thinks I do, what society thinks I do, what the government thinks I do, what I think I do, what I really do. So I hope that what I really do aren't depressing, and we do much more than that, but I thought you'd just enjoy those as a start. So what I'd like to do as a beginning is share with you 3 disclaimers. The first one, I have collected for the presentation material from a number of different sources. And with all of the discussion about plagiarism, I wanted to speak to this. What I've done is collected this information, and based on the format, it's hard to include all of the citations. At the end of the presentation, I will share with you some sources for additional information where I did gain a great deal of this information. Okay, the second one, I can't tell you what's on the test. That there's a clear firewall between the people who are writing the examination and the people who are presenting these webinars. What I am going to do is tell you what I think is important, what I teach in my introductory course, and that hopefully gives you some guidance. Third one is there's a balance, and I'm going to try to address that as I proceed today in terms of the wide breadth of information that is included in health policy and management, and the amount of depth or detail that we could go into. Many of the slides I'm going to share with you, we could spend an hour or 2 talking about them. That this ends up being an overview to refresh your memory. I can't teach one course, let alone multiple courses in the webinar. What I can do is help you think about what you do know and what you may want to go back and review more carefully to refresh your memories. Okay, with that said, what's the guidance I use beyond what I think is important to teach? And anybody who's participated in the other webinars has probably heard some of these things before. The exam is based on two things. One is the master's degree core competencies developed by what was then the Association of Schools of Public Health, now the Association of Schools and Programs in Public Health. And within that document, you would find the following definition and the following 10 competencies that all students, regardless of their area of concentration, should be able to display in the area of health policy and management. The second source of guidance I used, one other thing related to that one. Each of the 5 core areas is represented by one of those circles in the schematic. In addition to that, the ASPPH document referred to a set of interdisciplinary or cross-cutting competencies. I'm going to touch on several of those that I think would normally be also included in a course in health policy and management. To some extent, communication, I think that's frequently also addressed in social and behavioral science. I think the health policy and management course is frequently the site for leadership content, for professionalism and ethics, for program planning, and for system thinking. So I'm going to address those as part of my presentation. Second source I have, the National Board gathered a group of faculty who teach introductory health policy and management to assist in developing a content outline of what they thought was important to be included in a course, introductory course. I had the privilege of being one of those faculty members. I can tell you, as we looked at these issues, we had many more topics in our initial draft. What we would discuss in our telephone conference calls was, do you teach not-for-profit, for-profit, and government organizations structure in regard to the delivery system? And people would say, yes, I think that's important, we'd include it. If I thought it was important and other people said, well, that's very nice, but I don't think it's part of my course, we would carefully consider whether it should be retained. So I think those 2 documents are very valuable, again, in guiding you for preparation in this material. Okay, so as a starting point, let's do a quiz. Rather than having an online quiz showing responses, all I'm going to do is ask you to keep note of these, and we'll go back to these questions at the conclusion of the webinar, and we can see if you would have changed your answers, how many you knew at the beginning, how many you've gained information on as we proceeded. So this is just for your own information. These are, again, not questions that are from the exam, but things that I could see being on the examination. So the first one, receiving certification in public health, becoming a CPH from the National Board of Public Health Examiners, is an example of A, structure, B, environment, C, process, E, outcome. And I'll pause for about 5 seconds after each of these to give you a moment to make a decision. Okay, continuing on to the second question. The smallest percentage of U.S. healthcare spending addresses A, nursing services, B, public health services, C, physician services, D, pharmaceutical services, E, hospital services. Okay, continuing on to the third question. Potential injury to research participants is best addressed in the Belmont report by A, respect, B, justice, C, litigation, D, assessment of benefits, E, beneficence. Okay, continuing on to the fourth question. The U.S. Constitution empowers the detention of contagious individuals entering the United States, and this is a true-false question. Continuing on to the fifth question. Paying a monthly flat fee for all medical care needs is typical of A, fee-for-service, B, a health maintenance organization, C, a preferred provider organization? Sixth question, Shriners Hospital for Children would be classified as A, sectarian, B, investor-owned, C, state government, D, non-sectarian, E, federal government. Seventh, by February 1st, 2017, there will be a 0.2% reduction in HIV infections. Is an example of A, a mission, B, vision, C, objective, D, goal, E, program. Question number 8. Budgeting for the recurring monthly restocking of 10,000 doses of flu vaccine would be A, a variable cost, B, a charge, C, a fixed cost, D, a general cost. Okay, so let's go on, save those responses, and we'll address those at the end of the webinar. One of the things that I use as guidance about public health is the National Academy of Science Institute of Medicine report, The Future of the Public's Health in the 21st Century. And I think that it addresses the issue of policy as well as structural management. In the report, it makes 3 points. One, we need a health policy that assures adequate and sustained investment in the important determinants of health. The second, a strong governmental public health structure. And the third, it talks about a public health system that reflects public understanding that health is everyone's business. So that's how we're going to start out. With that in mind, I think that frames many of the topics we'll proceed and discuss. So as we go through the remainder of the webinar, I'm going to organize it around 4 topics: systems thinking, health policy, delivery systems, and health management. So let's begin with systems thinking. Some of you probably owned this game when you were little kids. I went to a store recently to check, and it's still available. All of the things in the illustration are pieces of plastic that you assemble as part of the game, the mousetrap game. And basically, this reflects a system. If you go to the center, I don't know if you can see my cursor as I move it around, but I'm pointing at part A. Basically, it has a crank. When you turn that crank, the teeth on that octagonal wheel turn the red wheel beneath it, which in turn eventually bumps the rail part C, which activates kicking a boot, which tips over a bucket, and out of the bucket this small marble falls down. It rolls down each of the steps where it gets to a chute and runs along the chute to point H, which bumps that pole with a hand at the top, which moves another marble, which falls into the bathtub, and it rolls around a while, eventually dropping out of a hole in the bottom of the bathtub, hitting a diving board, where at the other end of the diving board there's a man who's fired into the air, dropping into a tank, shaking a basket, which is the top of pole P, which eventually comes to the bottom, trapping the mouse. If you own that game, the challenge was something would always go wrong as part of that process between turning crank A and the mouse being trapped. That the marble would fall off the stairway, or the man wouldn't fall into the tank. So, you know, what we're talking about is a system. And in a system, everything has to work as planned for the system to achieve its outcomes. So in healthcare, and specifically public health, we have a variety of systems. One of the basic systems we all learn is the definition of health being a state of complete physical, mental, and social well-being. So it's the integration of those three components, physical, mental, and social well-being, along with not merely the absence of disease or infirmity. The World Health Organization goes a step further, and it defines all of the factors that are external to the physical, mental, and social well-being of an individual. Family, lifestyle, community, culture, the biosphere. So that's a system, and if there's anything disabling in the external healthcare system, it has impact on personal health. Another example of the healthcare system, if we think about personal health in the U.S. healthcare system, we have a variety of components. We have for-profit as well as not-for-profit healthcare. We have insurance that comes from a variety of sources, government, employers, personal health care insurance. There are a variety of regulations in the market. We have the need to generate revenue, both to sustain the system and for profits. So all of those factors become part of the system. And although I'm going to do my best not to speak to current politics, the inauguration of Donald Trump this week clearly has some impact on changes in the healthcare delivery system, and I'll speak to those very briefly later. Here's a more detailed version of the U.S. healthcare system. And as you can see, it has numerous interacting variables. If I tried to explain that system in a class, I would find it extraordinarily challenging. But it's an example of the complexity of the system, and I could probably take any item in there and trace it to its related factors and discuss it. To look at the entire schematic would take quite a while. More simple example of the healthcare system, public health. I think there are three important measures: cost, quality, and access to services. How much does the service cost? What's the quality of the care provided? And is it accessible to different groups? So once again, a system, but a much more simplified version than that one. As an example comparison of cost and quality, I came across this cartoon. Somebody hospitalized in the United States. I wish we had free medical care like in Cuba. The patient obviously is surrounded by all sorts of technology. Second panel is Fidel Castro prior to his death in a much more basic system, saying, I wish we had good medical care like in the United States. So what's the relationship between cost and quality becomes an important factor. Just a little bit of information about the cost of care in the U.S. We won't go into detail, but as you can see, we're talking about continuing growth in the total share of the gross domestic product consumed by healthcare expenditures, rising just in this time period, 2001 to the present, from 14.5% to over 19.5%. When I was a student, one of my mentors talked about the fact that if national health expenditures ever went above 10%, it would cause the entire healthcare system to collapse. Obviously, we're well beyond that. Where does the money come from? As you can see in this, the largest payer for healthcare expenditures in that 2010 total of $2.6 trillion was private health insurance, followed by Medicare, in turn by Medicaid, and the CHIP program, Child Health Insurance Program, and then other sources, including out-of-pocket expenditures for far smaller components. What do we use that money for? How do we spend it? We'll talk about the expenditures in public health a little bit later in my presentation, but the largest component, 31%, is going to hospital care, followed by physician and clinical services, 20%, other professionals such as physical therapists, occupational therapists, 7%, so on. One of the debates we've been seeing most recently, as you can see on the far left side, is pharmaceuticals being 10% of the total expenditures. I think one of the important issues in the system is diversity. Who has access to the services we provide? One of the most common things we talk about is differences between urban and rural areas in terms of the services that are available to people who reside in them. But there are a variety of other factors in terms of ethnicity, income, education, and so on. And I suspect all of you are aware of that. A few other ways we can approach the system's thinking in the healthcare system. The system requires financing, it requires human resources personnel, it requires facilities, and obviously it requires technology and supplies. Here's one other model that we can use to look at it. All of the external environmental factors. We have an external environment that's beyond our control in terms of ethics and law, politics, cultural and sociological factors, the public expectations related to the healthcare services we provide, economic and ecological factors. In addition to that, at the bottom of the page, you can see a series of healthcare environmental factors. Once we look at organizations, health services organizations or systems, excuse me, we can look at a variety of factors, the inputs, human resources, materials, technology, information, capital, patients or customers, along with other factors, and how they are converted through the structure of our system. The people were involved in the specific tasks, resulting in outcomes. Excuse me. One other more simplified model of Abedian, talking about quality, again talked about the external environment, but simplified the model, talking about the structure of the system, the processes involved within the system, and the outcome or results. And once again, using feedback to modify those and continuously readjust what we're doing based on our successes and failures. Here's an example of a model from the Institute of Medicine of the public health system. With our core function of assuring the conditions for population health, factors that play into this system include community healthcare delivery, employers, businesses, the media, academics, governments. CDC has a system as well, where they talk about 10 essential public health services that fall under 3 categories: assessment, policy development, assurance. And as you can see, under assessment, we begin with monitoring health, diagnosis and investigation, inform, educate, and empower, mobilize community partnerships, develop policies, followed by enforcement of laws, links to the provision of care, assuring a competent workforce and evaluation. And within that, there's a management component and ultimately research that drive this model. Okay, so that's just a brief overview of systems. If anybody has any questions, I'd be glad to address them now. Kate, if you're there, if you see any questions, could you assist me with that?
Sure, let's see.
I think it's pretty straightforward, so I'm not certain there will be any questions.
There are none.
Great, so let's continue on. if I can regain control of the screen. There we go. Okay, so what we're going to do is move to the second of those 4 components and talk about health policy. There are a lot of things that are being reported in the news with the change in presidential administrations. And my thought is that while we might touch on those very briefly today, the exam is not going to be modified to reflect any changes in legislation, including the Affordable Care Act in the next iteration of the examination. So even if there are policy changes, I would expect the questions on the exam to reflect the current model. Okay, so once again, I'll begin with systems, and what we're talking about is at the most simplified level, a relationship where we formulate policy, we implement policy, and ultimately we modify the policy based on its successes and failures. That may well be what we're going to see over the coming months in terms of changes in the Affordable Care Act. I think one of the things that stands out to me is that frequently there's a misunderstanding of the system and the policy used to implement it. The fact that somebody has a pre-printed sign saying, "Keep the government out of my Medicare," is an interesting statement in that Medicare is obviously a federal program. So government must be involved in Medicare. So anything that we may be talking about using Medicare as the example, there's a legal basis for its implementation. What we frequently do is go back to the historic policies that empower government to be engaged in healthcare. The U.S. Constitution, frequently people refer to the general welfare clause of the Constitution as the basis for our involvement in health, where it states to ensure domestic tranquility, provide for the common defense, and promote the general welfare and secure the blessings of liberty to ourselves. That's a very vague statement, but some people point to that as the basis for government involvement in healthcare. I think there's something much more specific that we would look to as our basis for involvement. The Constitution includes the Commerce Clause, which gives the authority to the federal government for isolation and quarantine. That is more detailed in Section 361 of the Public Health Service Act, where it empowers the U.S. Secretary of Health and Human Services to take measures to prevent the entry and spread of communicable diseases from foreign country into the United States and between states. So what we began with was service for people returning to the United States, specifically merchant marine, who may have acquired disease in their travels. There was the opportunity to examine, isolate, and quarantine those individuals. Excuse me. The same would apply for immigrants to the United States. So when we talk about law, we can divide it into 2 categories. Criminal law. Criminal law refers to conduct prohibited by government because it threatens and harms public safety and welfare. And we do have provisions of public health that address criminal law. Secondary category of law is civil law, actions intended to protect public health and its welfare and the welfare of people. So how do we do that? There's police power through law to encourage or discourage behavior. There can be specific coercive actions, quarantine I've previously referred to, the ability to seize property, the ability to close businesses. what we might do in terms of seizing property is talk about adulterated products that are imported to the United States. Closing businesses, perhaps the best example might be restaurant inspections for sanitation. Law tends to be very broad and empowers further activity. For many laws, there are also administrative regulations that are developed. Those would not require an action of Congress and the executive branch, whether we're talking about at the federal level or at the state level or even at the municipal or county levels. What we're talking about is administrative laws being developed under the authority of law and implemented by people with greater expertise, perhaps, than the legislators who developed the more broad legislation. So in doing so, what do we accomplish? Here's a brief checklist that I'd suggest if you were involved in developing policy. What's the problem? And you'll have copies of this presentation, so I won't go into all of the detail. But after defining the problem, gathering information that explains the background, the facts that are associated with addressing this problem. Landscape, what are the attitudes of the population? What are the environmental factors that influence it? Are there alternatives would be the key criteria or options. Do we have more than one strategy that might be considered? Which one would be ideal? And then finally, what would you recommend to address that initial problem? Just another simple little example of the same thing. Once again, in the system format, we're talking about those external factors at the top in terms of the environmental issues, developing policy, and then finally having some sort of feedback and an opportunity to modify the action based upon our initial successes and failures. In the case of legislation, we'll in all likelihood have different stakeholders with different interests as well as common interests. I think that typically what we'd be talking about in the lower right-hand corner are the consumers of the service, the patients, but in addition to that, there may or may not be different interests among the employers, providers of care, and the payers of care. Okay, so one other issue related to policy that I think is extremely important would be ethics. How do we allocate resources? In most cases, we're not going to have unlimited resources available for our use. And there are different ways to divide the pie up among the people who may require those services. The most equitable of those options would be equal shares for everybody. Everybody gets the same thing. But we could also talk about allocating resources based on giving larger allocations of pie or whatever the resource might be for those who've previously gone without those resources. We could say that people with the greatest power get the greatest number of the resources. We could talk about those who made the greatest contribution to developing the resource should gain the greatest share of those resources. We can talk about equal shares with the exception of special cases. Should we give children a greater share than we do adults? And finally, those with the greatest need get the greatest resources. So I like to use that example of how you slice a pie, but we'd be talking about a variety of healthcare resources. In terms of professional ethics, as public health professionals, I think one of the characteristics of a profession is the existence of a code of ethics. A code of ethics would have principles including communication to the general public of what our ideals are as public health professionals. I think that a code of ethics sets goals that we as public health professionals should aspire to. sets a minimum standard, the lowest level of what we might do, and still consider ourselves to be performing in an ethical and a professional manner. And it may also be a means to help us work our way through the most complicated of issues that don't have right or wrong answers. So in public health, and some of you may have be familiar with this either from a new student orientation or your graduation from a school of public health or a program in public health. This is Public Health Professionals Code of Ethics that's widely circulated. It began with some committees of the American Public Health Association. And I'll just briefly share this with you as a way of communicating the standards. As a public health professional, I hold sacred, my duties to protect and promote the health of the public. I believe the working for public health is more than a job, it's a calling to public service. Success in this calling requires integrity, clarity of purpose, and above all, the trust of the public. Whenever threats to trust in my profession arise, I will counter them with bold actions and clear statements of my professional ethical responsibilities. It goes on to say, I swear and affirm the following. I will strive to understand the fundamental causes of disease and good health and work both to prevent disease and promote good health. I will respect individual rights while promoting the health of the public. I will work to protect and empower disenfranchised persons to ensure that basic resources and conditions for health are available to all. I will seek out information and use the best available evidence to guide my work. I will work with the public to ensure that my work is timely, open to review, and responsive to the public's needs, values, and priorities. I will anticipate and respect diverse values, beliefs, and cultures. I will promote public health in ways that most protect and enhance both the physical and social environments. I will always respect and strive to protect confidential information. I will maintain and improve my own competence and effectiveness. Many of those statements link back to both the policy material we've covered and the systems thinking that I began with. How do we achieve protection for the people we serve? Again, many of you have worked with institutional review boards in regard to research activities. IRBs frequently cite themselves back to the Tuskegee experiment, which most of you are familiar with. If not, I certainly encourage you to look at the decisions that were made in withholding treatment for patients and as it would impact the outcomes of research. Based on that, we talk about the findings of the Belmont report, and there are three core principles to the Belmont report. The first is respect for persons, protecting the autonomy of all people and treating them with courtesy and respect, and allowing for informed consent, that the people we work with should be informed of the actions we're taking. Researchers must be truthful and conduct no deception in their research activities. The second, beneficence, the philosophy of do no harm while maximizing benefits for research projects and minimizing risks to the research subjects. And third, justice, ensuring reasonable, non-exploitive, and well-considered procedures that are administered fairly, the fair distribution of costs and benefits to potential research participants, and equally. So what we're talking about are really several outcomes based on the Belmont report. That there will always be informed consent of people participating in research, that there will be clear assessment of the risks associated with the research, and clear assessment of the benefits of the actions. And weighing that out, individuals can decide whether they will participate or if they choose not to do so. Okay, so let's talk very briefly about the implementation of policy. As I said, we're going to be watching a lot of headlines coming out of Washington over the next few weeks related to this. from your grammar school course dealing with government. Everybody is likely aware that there are 3 branches of government. At the federal level, we're talking about the legislative branch consisting of the House and Senate. In most states, we again would have a bicameral structure with 2 houses of the legislature. The executive branch at the federal level, the president, state level governor, and so on, as we move down to local agencies of government, mayors, county board presidents, and the judicial at the federal level, most senior being the federal Supreme Court. So as we look at those, we could certainly talk about the implementation of the Affordable Care Act, Obamacare, coming out of legislative and executive action, subsequently being reviewed by the Supreme Court. I'm not going to go into a lot of detail related to this in this session, but there's a nice brief video that's available, about 30 minutes in length, at YouTube, explaining how Congress works in the context of health care. And if you'd like to gain some additional insight, my suggestion is that this would be a good place to start. Okay, trying to advance, and it's not letting me do so. Bear with me 1 second. Okay, as you predicted, I think we've got a problem a little bit earlier than the previous session. I'm unable to advance. Thank you. Okay, so very briefly, I will talk about how a bill becomes law. Could you advance on to the next slide? I'm still not able to control the screen. Great, thank you. Okay, so if you could go back, I think we've suddenly skipped some things. Maybe I didn't regain control. Let me try. Okay, I've got it again, I think. Yeah, it skipped way ahead. It must just be very slow. Okay, so if I could get back 1 more, it's saying I'm controlling it. It's not letting me go back to the next slide.
So I'll just give it a minute, because if you keep pressing back, it's going to keep going back.
Right. Okay, there we go. Okay, I think it's just responding very slowly rather than not responding at all. Okay, I was trying to go 1 slide further, but in the interest of time, I'll use this one, which is a little bit smaller image of the same information. If we're talking about a congressional effort to implement a new healthcare law, it may begin in either the House or the Senate. In many cases, there will be some sort of concurrent agreement where there will be, still going backwards. I'm not going to touch the cursor for a moment. Let's see if it'll go back to where it should be. Basically, I'll speak without that image being on the screen. Members of the Senate and or the House would introduce a bill, a proposal, which in turn is assigned to a committee for further consideration. At the committee level, there will be hearings, potentially modification of the initial legislation, and a vote on whether it should proceed out of that committee for further action. I'm sorry, we still haven't advanced. I will try to push it 1 forward. Okay, there we go. Once it leaves the committee, it will be considered by the entire House or the entire Senate, and there will be a vote on whether to pass it or to reject it. In the event that it's rejected, that's the end of the proposed legislation, the bill. If it passes in identical form from both the Senate and the House of Representatives, there's not a problem. It can move on to consideration by the President. In the event that there's some variation between the bill in the House and Senate, It would then go to a conference committee consisting of members from both the House and Senate, who would then try to hammer out those differences, returning it to both the House and Senate for final vote of approval. Once it is approved by both, the bill is then forwarded to the President, who has 4 options in regard to the legislation. They may not amend the legislation, of course. If the President is supportive of the bill, they sign it into law. If there's a congressional session in place and the President chooses not to sign the law, 10 days after it's forwarded to the President, it automatically becomes law. Third option, if the Congress is not in session and the President chooses not to sign it, it will not become law. And the fourth option is the President does not support the legislation and vetoes it. At that point, it will not become law, with one exception. If the members of both the House and the Senate, by majorities of 2/3, vote to override the veto, and that requires both houses, of course, it automatically becomes law without support of the President. So some familiarity with that process is important. If we look at the executive component, I began by talking about the President. There are a number of agencies of government within the executive branch that are involved in the implementation of law and regulation. This is a schematic that simply shows the units within the U.S. Department of Health and Human Services. There are a variety of other units of the executive branch that are involved in public health, which I'll share with you in a moment. But as you can see in this illustration, we have assistant secretaries in a variety of settings: children and families, aging, Medicare and Medicaid, healthcare research and quality, CDC, toxic substances and disease registry, Food and Drug Administration, Health Resources and Services Administration, Indian Health Services, National Institutes of Health, Substance Abuse and Mental Health Services Administration, and so on. While we think about the Department of Health and Human Services being the primary focus, there are public health-related activities across government. We have cabinet-level agencies: agriculture, commerce, defense, education, energy, housing and urban development, Department of the Interior, Justice, Labor, Department of State, Transportation, Treasury, Veterans Affairs, all involved in the provision of health care within the U.S. Just as examples, what would the Department of State be involved in? PEPFAR, the President's initiative related to HIV at an international level. Department of Agriculture in regard to food safety. We also have a series of federal agencies that are independent, and those are listed to the right side of that chart. So the involvement in public health activity throughout the federal government is quite extensive. Just as a couple examples, and I don't think you need to know details of every piece of healthcare legislation to do well on this examination, I thought I would share a couple of the key pieces of legislation related to healthcare in the U.S. Going back to what I referred to in the Commerce Clause, in 1798, Congress initiated an action, a law, for the relief of sick and disabled seamen, which appears to be the first federal involvement in health care. In 1906, Congress enacted the Pure Food and Drug Act, which was intended to ensure the safety of food and cosmetics and the safety and efficacy of prescription drugs and medical devices. In 1918, while it's not an explicit law, that was the year the federal government provided states with funding for public health services. In 1924, we saw the Veterans Act of 1924, which codified the specific healthcare services the federal government would provide to military veterans if they're injured in the line of duty. 1935, the Social Security Act, which provides specific benefits to the elderly and other specialized populations. 1963, the Clean Air Act, which established federal enforcement in interstate air pollution and assistance to both state and local governments in controlling air pollution. 1965, the illustration that I had at the beginning of the section, Lyndon Johnson signing into law two programs, Medicare and Medicaid. Frequently people get those two programs mixed up. Medicare referring to medical services for people who qualify based on age or specific medical needs. Medicaid program providing payment for medical services for people below a specific income level. 1985, we saw the Consolidated Omnibus Budget Reconciliation Act, which is referred to as COBRA, which talked about health insurance and giving employers, employees, the ability to carry health insurance with them when they left the job to either a new job or unemployment. It also addressed hospice care as part of Medicare and Medicaid. Again, I'm trying to advance. We'll bear with us a moment. Hopefully we'll take us to the next slide soon. I apologize, but our system is slow today. Kate, can you try advancing it? I've tried a couple times and it may start to skip ahead, but I'm unable to move forward.
My screen is showing the patient protection.
Now it's jumping all three at once. Okay. I regained the control. I don't know what was delaying it, but we're back in. Thanks, Kate. 1996, Health Insurance Portability and Accountability Act, referred to as HIPAA, addressed continuity of health insurance. It also addressed medical savings accounts. It talked about access to long-term care services, and it also talked about protection of patient confidentiality and information. 1997, the State Children's Health Insurance Program provided medical care to children of low-income families that were above the line required for Medicaid eligibility. 2003, Medicare Part D, that provides pharmaceutical benefits for Medicare recipients. And in 2010, the one that's receiving a great deal of national discussion currently, the Patient Protection and Affordable Care Act, also known as Obamacare, which was to provide for expansion. The current estimates are in the range of 20 million people have gained insurance through this program following its implementation. So, as I said earlier, there's some degree of uncertainty. At this point, we now have both the House and Senate voting for repeal of the Affordable Care Act. Donald Trump, over the past week, has talked about a plan which would expand services, which has not yet been released. As I mentioned earlier, since the exam is prepared in advance and carefully designed based on a test bank, it would be highly unlikely to see any questions that would address the changes that we are seeing in regard to healthcare legislation in this transition from President Obama to President Trump. Okay, nonetheless, I imagine, again, since I can't speak to what's precisely in the examination, it is possible that there could be a question or two about the Patient Protection Affordable Care Act. I won't go into detail in that regard as part of this presentation, but again, referring you to YouTube, there's I think it's about 4-minute video that does a very brief overview of the Patient Protection Affordable Care Act. And I think that would be sufficient if you want additional information in regard to the ACA. So, as I said, it's incredibly difficult to predict where we're headed this year. I imagine the only thing we can predict is it's likely that we will see some changes occurring. Okay, so that wraps up my comments in regard to policy. If there are any questions, I would welcome them at this point.
Okay. Does Commerce Clause distinguish between citizen non in quarantine, i.e. anyone trying to enter the U.S. with disease symptoms was subject to quarantine?
As a non-lawyer, I believe it would apply to any individual returning to the United States. And as an example, if you'll recall, there was a nurse from New England who returned to the United States from Africa working with patients with Ebola who was quarantined in New Jersey. I believe it would apply to any U.S. citizen returning to the country. But as I said, I'm not an attorney. So I doubt once again, not knowing the questions on the exam, I doubt it would be that narrow and that focused. Anything else,
There's
Kate?
another question. Yeah, there are 2 more questions. The study guide has health economics on it. Can you comment on health economics?
Yeah, I'll get to that a little bit later in the presentation. I'll speak a bit on economics as we move further into the presentation.
Okay, one more question is, you have substantial depth on the federal process, but a lot less on the local and state policy. Any thoughts?
Right, that's a good point. And the reason that I focused on it is my assumption that if you're taking the examination in Washington State, we couldn't expect you to know specific details about regulation or statutory authority in Illinois or Georgia. Now, the structure in most states would be the same with 2 houses of government in their state legislature. I believe we do have one state that has a single unicameral body. If we talked about, excuse me, health departments, and I'll get into this a little bit further later in the session, if we were talking about variation in one state versus another in the structure of county health departments, or if we were looking at city health departments or multi-county health departments, there is going to be some variation. I don't think that the examination can fine-tune those questions and expect everyone to have detail related to the unique characteristics of California versus Montana. And as a result, I would assume that the state and local questions will tend to be much more general, and the focus will be predominantly at the federal level. And I think that in most states, the federal model is reflected in states, state governmental structure with similar responsibilities for the governor to the president. I hope that helps. If not, please follow up with another question.
Okay, there is one other question. Yeah, sure. There's one other question that came in. It says, the study guide also includes national advocacy organizations. Can you comment on this?
Yeah, once again, I'll get to this a little bit later. This is one of those things where it's a system where it's hard to cover all information possible. Just very briefly, one of the things that I was reading this morning, again, relates to change in the presidential administrations and congressional impact in regard to Planned Parenthood as an advocacy organization. Excuse me, but we will get to that again a bit later. I'm trying to decide if we should go for a break now or hold off a little bit later before we move into the next topic. Why don't we take a 5-minute break right now, and I'll pick up from there in precisely 5 minutes. Okay, that's 5 minutes. So let me welcome you back again. And what we're going to do is pick up talking about healthcare delivery systems in the continuum of care. So let's talk about the role of public health and how it fits into the context of all healthcare delivery. We tend to think most about public health in the context of governmental agencies, whether they're local, state, or federal agencies. But there are also roles clearly in the private sector for public health, and we'll talk a bit about that. At the local level in government, what we're typically talking about are community-based health departments that are based on geopolitical boundaries, as I mentioned before the break, county government, city government. In rural areas, it may be more common to see multi-county, bi-county, or tri-county health departments based on low populations and more limited resources. In thinking about it, I thought I'd share with you some information from the Trust for America's Health. And as you can see, we do have wide variation in specific measures of the population. The final two columns of the table, of course, being the highest or worst rates, followed by the states with the lowest or best rates. As you can see, as an example, under uninsured population, we have variation between 3.3 and 19.1%, with an overall average in the U.S. of 11.7%. In terms of diabetes, and I thought the following three would be interesting, as you'll see in a moment. Highest diabetic rates in 2014 were in West Virginia, almost double that of Utah. Drug overdose deaths in West Virginia, 12% versus just slightly over 2% in North Dakota. And we'll look at hypertension as well. In West Virginia, 41% of the population. In Utah, about half that, 24.2%. So with those as potentially disappointing measures of the health of the population, let me ask you to take a second. CDC identified the top 10 achievements in public health over the past century. Before I share them with you, let me give you a moment and just try to write down one or two items that you think would be on that list. And I'll give you about 30 seconds for that. Okay, compare your thoughts to this list. CDC says the major achievements are vaccination, motor vehicle safety, safer workplaces, control of infectious diseases, decline in deaths from coronary heart disease and stroke, safer and healthier foods, healthier mothers and babies, family planning, fluoridation of drinking water, recognition of tobacco use as a health hazard. So some of these we would, working in public health, we would almost take for granted at this point. I'm not sure that all people in the population would agree. Okay, so we've talked about federal agencies. Obviously, the one that likely gains the most attention is Centers for Disease Control and Prevention. And if you simply look at their website, you'll see an array of the services they provide to the public. One of the interesting things as I began the presentation, the public presentation tends to be much more focused on these sorts of things rather than automobile safety or maternal and child health. If you want to understand the relationship between CDC activities and local health, there is a movie I think it's a great movie. I use it in class, Panic in the Streets. It was released in 1950, starring Richard Widmark as a U.S. Public Health Service officer in New Orleans. It's available from almost any of the download movie sites, from Apple, from Netflix. I believe that it's available through Amazon. And I think all of them price it at like $2 or $3. Someday when it's rainy and you're at home, it's worth watching if you're interested in public health. Okay, state departments perhaps have a more focused set of activities. Here's an example using Minnesota as an example. I think one of the interesting things that most state departments do, and it varies with the state of course, is record keeping. Frequently they are the keeper of birth and death certificates. But they also have clear responsibilities within the state related to promoting public health. And again, that there's going to be variation from state to state, but we're going to see commonalities across all states. At the local level, as I've mentioned earlier, there's going to be a lot of variation in regard to how the services are organized and the array of services. One of the useful sites to look at this is NACHO, the National Association of City and County Health Officers, and they'll be descriptive of a variety of common activities in regard to their logo in the upper left-hand corner, addressing prevention, promotion, and protection of public health. We've all watched what happened in Flint, Michigan in regard to responsibilities related to water quality. Obviously, that would be an example related to the prevention, promotion, and protection. I mentioned earlier the allocation of funding toward public health. Here's some information. The most recent thing I could find was in 1993, which suggested less than 1% of all healthcare expenditures in the United States went to public health. I have no specific factual information, but as budgets for public health activities have declined, particularly at the state and local levels, I'm inclined to think that it may even be a smaller percentage of the total at present. But I think the key is that it's an extraordinarily modest component of our total healthcare expenditures. If we look at state budgets, you can see substantial variation. And the reason I picked out West Virginia in that preceding slide, most interestingly, if you look at healthcare expenditures per capita, per person, the public health budget in West Virginia is the largest of all states at $220 per individual within the state. Nonetheless, they have some very deplorable outcomes in regard to public health of its population. And that continues down to the median, South Dakota. What I did, since it wouldn't all fit on the page, is I continued on to the bottom of the rankings. Nevada only spends $4.1, $4.10 per person on public health. Missouri, $5.90. So we're looking at an extraordinary variation between West Virginia at $220 and fairly substantial problems. Hawaii, $158 and much better health status, and the states of Missouri and Nevada being, less than $6 each. It's really surprising to me that there's this much variation. Okay, so once we talk about the funding that's going into health departments, where does it come from? And this is 2009 data from NACHO, saying that local funding sources, counties or municipalities, are contributing 25% of the funding to their health departments. State pass-through monies, the states are providing support at the range of 20%. Federal agency pass-through funding, slightly smaller at 17%. Fees providing about 11% of the budget. Medicare and Medicaid in the form of clinical services reimbursement, a combined coverage of about 15%. So the local health departments are receiving their funding through a variety of different sources, but you know, it's still a challenge in terms of constructing a budget. Okay, so then let's talk a little bit about the private sector. As I said, I think most people think about the public sector activities in regard to public health, but there are a variety of things. One receiving a good deal of controversy in the past year is corporate funding from Coca-Cola in regard to sugary drinks, that Coca-Cola promotes the fact that they have a variety of programs related to fitness. At the same time, there are criticisms related to the sugar in their beverages and obesity. Industrial safety in most settings is certainly an occupational and environmental aspect of public health. Research, particularly in the pharmaceutical industry, is private sector activity. Let's talk a little bit about personal health. Well, we can talk about our different levels of services. Despite not being part of a local health department, most outpatient services in physicians' offices and clinics address preventive services, address health promotion activity. Primary care. We're seeing this clear trend of walk-in clinics. Traditional physician offices and clinics are now being complemented by walk-in clinics in a variety of settings. This is an ad for a walk-in clinic at a Walmart store. We're seeing more and more supermarkets that are becoming involved in this. On the pharmaceutical side, both CVS and Walgreens are increasing the number of walk-in clinics. As this ad cites, in many cases, no appointment necessary. You walk in for your flu shot or diagnosis of acute care problem. Hospitals, in terms of secondary and tertiary care, we see a variety of hospital settings in the United States. This is a chart that tries to talk about the variations in ownership. Once again, we see the difference between private and government activities. If you look at the top third of the page, we're talking about voluntary, not-for-profit agencies, and I'll speak to this again later, but I think the proper label is not-for-profit rather than non-profit, and I'll explain that in a short time. On the other category, there are investor-owned facilities, which tend to be for-profit, seeking to have some sort of financial benefit for the owners. Under the voluntary facilities, we can divide them into sectarian and non-sectarian. Sectarian is talking about facilities that are affiliated with a religious denomination. And as you can see, there's a long list of denominations listed under sectarian as operators of facilities. Under the non-sectarian, we see a variety of activities. There are community hospitals. There are hospitals that are operated by industry, not-for-profit organizations. If anybody is in the program from the West Coast, you're probably very familiar with Kaiser Permanente health plans. And then we see the not-for-profits that serve specialized populations. My question earlier addressed Shriners Hospital. I've noticed on television recently a number of ads for St. Jude's Hospital. Those hospitals provide services to specific populations. They may have policies in regard to the ability to receive care regardless of ability to pay. On the investor-owned side, we're talking about hospitals that are owned either by individuals or partnerships or large corporations that own many hospitals. They can be a single facility or they can be a system of healthcare facilities. The goal in those, of course, once again, is as in all investments, that the owners will receive some sort of positive benefit through their investments. Okay, at the government level, just like the things we were talking about earlier in regard to legislation, we can see variation at the federal, state, and local levels. At the federal level, we have extensive activity in terms of hospital services in the U.S. Department of Defense. Each of the branches of military provides healthcare services, as does the Department of Veterans Affairs. U.S. Department of Health and Human Services also operates hospitals for specific populations, the Indian Health Service being an important measure. Hansen's disease, previously referred to as leprosy, currently operates a facility in Hilo, Hawaii. The U.S. Department of Justice prisons must also operate healthcare facilities for the inmates in those facilities. At the state level, we have really several categories. Historically, there was care for chronic disease in the 40s. We saw hospitals to isolate, quarantine residents with tuberculosis. Now most state facilities have moved to long-term activities related to mental health and psychiatric services. But there are still many state universities that operate health academic medical centers, which are part of state governments. At the local level, we have a variety of activities. Large cities frequently have city hospitals. Sometimes we see city-county combined efforts or county hospitals. In some cases, we have specialized hospital districts that provide care, organizing hospitals around those services. So we have a variety of organizational structures with different missions, different policies related to reimbursement, different policies related to eligibility to use their services. Okay, and I'm trying to advance again. Hopefully we can do so. Okay, next level of the healthcare continuum, services for the aging. And there are a variety of services. The illustration, you can see two people who are in a long-term care facility who are bowling using a Wii and a video screen. We certainly have home health care services for people with people visiting their homes. We have senior living communities for people who don't require extensive services but are aging and may require some services. Nursing homes, retirement communities. And we can talk about a variety of services, including the traditional health promotion activities that would be offered in all of those settings. How do we pay for care? The most common model in the U.S. remains fee-for-service. It's not dissimilar from the way we pay for most activities that we are involved in, whether it's having automobile repair or buying food or any other commodity, that somebody looks at the service you're consuming, attaches a specific price to it, and charges you based on the intensity of the service that's being provided. And those bills tend to go to both the individual for certain services, particularly outpatient care. For inpatient care, we may have supplemental insurance, either the public categories we refer to or private insurance. Second way we're seeing care provided with growing interest going back into the 1920s in the United States is managed care, typical model being the health maintenance organization, where an individual pays a flat fee for all care they require both on an inpatient or an outpatient basis through the entire continuum of care. The goal in these settings would be to minimize cost, to keep it below the total expenditures or the total income generated through the prepayment. And one of the ways to do that is by promoting good health rather than treating severe illness when it occurs. How does the U.S. do overall in our health care? Here's some information from the health that was provided by the Commonwealth Fund. This was in 2014, looking at overall healthcare rankings, and among 11 different nations, the U.S. ranked 11th. And I'll share a little more information about that. Here are the categories that were used in scaling that information. As you can see, the U.S. ranks 11th overall. We do best in, let's see, access, cost-related problems, efficiency, equity, and healthy lives. We perform most poorly in effective care, timeliness of care, patient-centered care. And if you look at the bottom row of the list, we are the most expensive of the countries in terms of our per capita cost per individual. So we're $8,500 compared to the United Kingdom, where they ranked #1 and also are only spending $3,400 per individual. Okay, just this week, U.S. News reported again on public health care systems. They did this based on a survey of 16,000 people in 60 different nations. In their listing, the U.S. healthcare system ranked 15th. There was no information about the methodology other than to say this was by perception among the individuals who were surveyed. The highest ranking system among the list was the Danish system, and I found this very interesting, again, because of our most recent presidential election and, strong feelings that appear in the United States related to taxes. Danes pay the highest taxes among the population surveyed in these 60 countries, and they also have high-quality public health and social benefits. What's interesting, as part of this survey, they also identified Denmark as the happiest country in the world. Despite it being directly across the border from us, Canada was ranked #3 in terms of having the most well-developed public health care system. One of the things that's most interesting is that despite it being highly ranked, we know that there are a large number of Canadians who cross the border to come to the U.S. to seek health care. I think that that may go back to the issue of access rather than cost that we described as we first began our webinar. So just out of curiosity, if you'd like to see the remaining lists of the countries in the top 10, there they are, mostly Western European countries, Australia and New Zealand also being on the list. Okay, let's talk real briefly about preparedness. I can't imagine, and again, I'm speculating as I say this, I can't imagine that there will be extensive discussion of preparedness on the examination, despite it being a very important topic. I think that most of the faculty who teach this type of course in an MPH program find very little time to address this topic, perhaps a single lecture. The illustrations on the screen are from the 50s, when we talked about school kids in the United States preparing for nuclear attack by the Soviet Union by hiding under their desks is the model of preparedness. I think during that time period we also talked about Civil Defense Administration having emergency food and rations stored in basements of office buildings. There were some people who built fallout shelters in their backyards. I think that preparedness is focused on a very different area in recent time rather than nuclear disaster, thinking about terrorism. This is a slide, interestingly, that was provided to me by a student who participated in the NBPHE review session at the American Public Health Association meeting last fall. And I thought it was a better illustration of the same topics than the one I previously used. I think that the key understanding that you should consider in regard to preparedness is risk reduction, and there are 5 steps related to that. The first one is assessment in terms of hazards and our vulnerability to those hazards. Second one is what are the implications of such a disaster? If it occurred, what would happen? Weighing those things out, we would then talk about what we can do in order to prepare for that disaster and its occurrence. If it does occur, what would we do? Fourth one, is there something we can do to prevent the occurrence of the disaster? Is there some way we can avoid its occurrence? And the final step being mitigation. If it does occur, what can we do in regard to mitigation of its consequences? I think if you look at those steps, that's probably, and again I'm speculating, that's probably sufficient to cover this topic on the examination. I found this interesting on this topic. A survey from Chapman University in 2015 indicated that more than half of all Americans fear they will experience a natural or man-made disaster. However, while 86% of the survey respondents believe that a 72-hour emergency kit recommended by FEMA and the Red Cross would improve their chances of surviving a disaster, 72% of the respondents said that they do not have such a kit. They've made no effort to prepare for a disaster. So going back to this issue, in some way they've identified their vulnerability, but they're ill-prepared to deal with a disaster occurring. Why? As you can see at the bottom of the screen, their assumption is that they don't need an emergency kit because there would be first responders who would protect them and come to their aid in the event of a disaster. I guess, you know, the general assumption may be unrealistic that we're prepared to do so, but it does indicate to me that the general public does have a high level of confidence in the infrastructure of the government to protect them. I wish we had a way to poll this. I should have added an opportunity to poll the participants in the survey, see how many of you do have an emergency kit ready to go. Okay, so let's take a moment just to talk about the delivery system. If there are any questions related to it, I'd be happy to entertain them at this point. Kate, any questions?
Let me just check 1 second.
Thank you.
It doesn't look like there are any, no.
Okay, well, if anybody thinks of anything as we proceed, you're more than welcome. At the end, we'll do a recap. Okay, let me regain control of the system. Okay, so this is our final session, or section of the session. We're going to talk about health management. And the illustration is something people frequently use when they talk about the pillars of quality in healthcare delivery: the service we provide, the level of quality, the human resources, the people engaged, the financial aspects, and the aspects of growth related to the organization. So let's talk a little bit about that. First component, people pursuing the CPH credential, I assume that you envision yourself as leaders in public health, and I congratulate you for that. What does a leader do in terms of management? If you were pursuing an MBA degree, or if you have an MBA, you probably discussed the model similar to this, that in making decisions you consider 5 functions of management. How we organize our services. Not only the structures I've described as we've gotten to this point, but the relationships between the people that are involved in the provision of services. Staffing. How do we acquire, maintain, and retain our human resources? One of the things that I think is taking place right now, and we'll talk about it a bit later, is a large number of people in the public health sector who are reaching a point where they're eligible to retire, and how many people will leave their jobs based on retirement. Directing. A leader would be responsible for directing the subordinates that work for them within an organization, defining their responsibilities and assuring that they complete them. Controlling the activities is the ongoing implementation with your plans, and then finally the planning of your activities, what you want to accomplish. If you can effectively lead in each of these 5 areas, I think that's a key component of being an effective manager, an effective leader in an organization. One of the interesting things that people frequently miss in an organization is who they work for. If you were the executive director of a public health organization, of a hospital, of a medical group practice, typically, rather than having full authority, governance provides for someone, or I'm sorry, not someone, but a group of people who serve on a board of directors, a board of trustees, a board of commissioners, some title like that, who are either elected or appointed, who supervise the general direction of the organization. It's an important difference between the responsibility of the board of directors or trustees and the executive director. Typically, the board of directors has a role in defining the overall policies of the organization, refining the mission of the organization, where the executive director is responsible for the day-to-day responsibilities achieved in implementation of that mission. So if we're talking about the relationship between those groups, we wouldn't want the board of directors to be involved in this case, looking down under the private duty manager, hiring the nursing staff. They would make decisions related to whether we needed a nursing staff, certainly with the advice of the professional advisory committee, the executive director, and others. But they would make that decision. They would make decisions in regard to the annual budget of the organization and how large a nursing staff we might be able to afford. So it's important to look at that relationship. The board of directors, or whatever the governing body is called, typically would be responsible for not only the mission, but the hiring and firing of this executive director. But in turn, the executive director would be responsible for the day-to-day operations, including the management, hiring and firing of all of the subordinates within the organization. Okay, so let's talk real briefly about organizational charts. That, you know, I think that in the practice examination at the NBPHE website, there is a sample question related to this topic. There are 2 terms, line and staff, which we see in organizational charts. Typically, line refers to the individuals who direct actions that advance the organization's core function or work, where the staff are the people who provide some sort of assistance to the line personnel. They support the line personnel in their activities. So in this illustration, we have a director of public health who has direct line authority over the associate director for patient care and the associate director for environmental services. We also have two people who have staff roles. The executive assistant to the director doesn't have direct authority over any employee, but assists the director in achieving the organization's mission. The same might apply to the medical director in the relationship to the associate director for patient care. Okay, so there are basically four ways I can see organizations developing their structure: function, geography, client, and purpose. So if we were talking about a public health department, the director might organize activities related to functions: planning, public relations, human resources, finance. Or they may organize it differently. If it's a large service area, they may say, I'm going to assign somebody as the associate director for the North Division and a separate person who's totally responsible for the South Division of the health department. We could also organize things around clients who we serve in the health department. And as examples, we could talk about children, adolescents, adults, and senior citizens. Or we could organize the public health services around specific purposes: well baby clinics, health promotion, substance abuse. While it's easy to draw these clear lines based on function, geography, client, and purpose, I think what's more typical is a model that looks like this, where we end up with a mix of those activities, where the director may have each of those different structures organized. And we may even go a step further, and as you can see, the North Division has organized its activities differently than the East Division. No, I'm sorry, I misspoke when I said that. The North Division has organized its services differently than the South Division. Correction on that, I apologize. Where they've looked at their populations they serve, and with the autonomy the director is provided to the people responsible for the divisions, those division directors have organized their services differently. There's one other way that organizations may define themselves. I think that this one is much more complex and probably less common. But if you hear somebody talking about a matrix organization, this is what they're talking about, where they've divided their organization using more than one of these models. As you can see, across the top we have an organization where we have activities divided in one set of functions, where horizontally we have them organized differently. So basically what we're saying is that under well baby services, we have somebody who's the director of well baby services who also, the person in charge of well baby services also has responsibilities through direction of the planning department for planning, public relations and communications for those functions, human resources, once again for human resources, and finance dealing with their budget. Much more complex. It probably means that the person in any of those boxes for planning, communication, resources, or finance is reporting two different ways, horizontally and vertically, and in effect has two bosses, which makes their jobs much more complicated. There have been efforts at developing matrix organizations to improve performance. I cannot personally think of a local health department that I'm aware of that uses this model, but I'm sure there is one. Okay, so let's talk a little bit about human resources, the issues of recruiting, screening, and hiring. Ideally, what we want to do is attract the best possible people to our organizations. We want to reward them for their jobs. Salaries may be an important factor. I'll show you some salaries in a moment. If we can pay people better, it probably increases the likelihood of retaining them. We want to give them authority through empowerment. We want highly motivated people. We want them to come in with appropriate education, but based on a changing environment, we're certainly concerned about additional training to keep them at the best of their abilities. So what we might do is develop job descriptions for every member of our staff where we talk about their individual characteristics, the characteristics of the specific job we're hiring them to fill, and then finally work environment characteristics, how they function within the structure of our organization. Some of you are probably familiar with McGregor's theory of human motivation. I think this is something that's commonly discussed in regard to these issues. McGregor frequently talked about what's called Theory X, or classical approaches to management and human motivation, versus Theory Y, or behavioral approaches. Theory X basically said that employees are motivated exclusively by their salaries, that if they had a choice, they'll do the minimum amount of work. If they're on an assembly line, they don't need a lot of training beyond their specific function. If somebody's doing restaurant inspection, they need to have little preparation in regard to preparedness if a disaster occurs, because they're only doing one thing. A lot of people who believe in Theory X think that employees can easily be replaced. If you don't like it the way we do it here, you can always leave and I'll hire somebody else. On the other extreme, the Theory Y behavioral approach talks about employees who are highly motivated in their jobs, that they love their jobs, and while their salary is certainly important, what they accomplish through their job is equal or more important. And my experience with people in public health is they're highly motivated related to their jobs, rather than simply seeking to show up at a specific time and go home as soon as their work hours are completed. I think that what's more important is that we may need to talk about a contingency model where not all people are alike, that individuals are not all the same, jobs are not all the same. So we've talked about, in some cases, people refer to Theory Z, or the contingency theory, which is situational, that not all employees are the same, that some employees are going to be far more motivated by one thing or another. Some are more motivated by salary. Others are more motivated by the accomplishments of their jobs, and that the nature of their job may be very different. If we're talking about somebody who's doing a very routine job as a restaurant inspector, where they do the same thing over and over and over every day, their motivations may be very different than somebody who's dealing with a well baby program. And what we might find ourselves doing is needing to evaluate the situational needs to effectively supervise those personnel, and they may be different. Okay, let's talk a little bit about planning. One of the other key components, the functions I referred to, is planning. We talk about means and ends. People use the terms mission and vision. Mission tends to be more specific than a vision. In terms of means, we talk about strategies and tactics. One of my questions talked about goals and objectives. Goals, and I'll show you in a moment some examples, tend to be more long range, more broad in focus. Objectives tend to be shorter in their time frame and very much more specific. And in my question, as you'll recall, I was very short term and very detailed. Okay, so what are we doing in our planning? We're looking at the 4 questions on the left side of this slide. what we're going to do is try to analyze the situation and answer where are we now. We want as much detail as we can in terms of the current environment. Frequently, people do SWOT or WATS analysis, strengths, weaknesses, and opportunities and threats. And based on that activity, analysis of data, and our assessment, we identify the priority issues and challenges for a specific organization. We also consider alternative ways of dealing with those issues. And what that leads us to is the second question: where should we be going? And in that, we try to define our direction. We talk about the organization's vision and mission, our goals and objectives. So from there, we develop strategies. How should we get there? What are the specific actions we're going to take, our programs that we're going to use to achieve the goals that we've identified for the organization? Ideally, we have unlimited resources, but rarely is that the case. As a result, as we're developing our strategies, we're going to have to consider the cost for those strategies, both in terms of equipment, capital budget, and operating budget. We'll talk about both of those terms shortly. And then we're finally going to be moving into, are we getting there? We have growing interest in health information systems to gather and monitor our data. We're going to continue with our evaluation process. And based on the feedback, we're going to adjust both our performance, how we try to achieve the objectives, and our objectives. One of the things that stands out to me is if we set a goal of reducing infant mortality in the United States by 10% over the next 5 years, that may be well achievable. If we said that we were going to have 0 infant mortality within 3 months of the date we start, it's highly unlikely that we would be able to achieve that. Nonetheless, any feedback we have about our successes and our failures becomes feedback as we replicate this process. Organizations tend to have 1-year, 3-year, 5-year plans. I think it's hard to have a 1-year plan. We can have an implementation plan over the next year for perhaps a 5-year strategic plan. But in some way, we're going to develop a model. If we don't do that, we haven't defined what our priorities are, how we're going to achieve them, how we're going to monitor our successes and failures. As I said, there are a variety of plans. Just browsing the web, here are some samples of a variety of plans I came across. As an example, most of you are probably familiar with the federal Healthy People model. Here are some examples from Healthy People 2020. This is a 10-year model that if you look, you'll find Healthy People 2010, Healthy People 2000, Healthy People 1990, and so on. In this, what we've got is a goal that in maternal, infant, and child health, we have a goal to reduce the rate of fetal and infant deaths in the United States. And that would be over the time period of the next decade. It doesn't detail in any way the measure of what the reduction is. But when we look at the objectives, they're much more specific. Reduce the rate of fetal deaths at 20 or more weeks of gestation. Reduce the rate of fetal and infant deaths during perinatal period. Reduce the rate of all infant deaths within 1 year, and so on. And as you can see, if you went to the website, at the far right, there's a button you can click for additional details on each of those objectives. Personally, I like the idea of having goals and objectives that are time-specific. Goals are much further into the future than objectives. And if somebody asks me, how are you doing? If I reduced infant mortality by 1 case, I could say I'm doing well. I like to see goals and objectives that are not only time-specific but measurable, a reduction by a certain number or a certain percentage. And in Healthy People, they talk about how those goals and objectives all play into a system of determinants of health, ultimately changing the health status of the population. And that's just one example. Somebody asked about economic terms earlier. I think that without going into detail about economics, the first step is this slide that I think there are 3 terms you should be familiar with. Needs, wants, and demands. Needs talk about a state of felt deprivation in regard to physical, social, or individual needs. A good example is hunger. If you're hungry, you need sustenance, you need food. Wants talk about the specific action for that need. What are we going to do based on culture and individual personality to address hunger? In some cultures it might be bread, in other cultures it might be something else. And then demand becomes a final consideration, what we're willing to pay for. If I'm hungry and I want the finest steak at the finest restaurant, do I have the money to purchase it? If I don't, I may say, well, I'm going to reconsider and I'm going to go to McDonald's instead. So I think it's important to know those 3 terms, needs, wants, and demands. Another management topic that I think is important is in regard to marketing. People talk about the 5 P's, or in some cases the 4 P's of marketing. And those are product, price, place, promotion, and people. In the case of what we do, what people in business would traditionally talk about as a product, I think of as a service. And what I've done is I've created a matrix for the 10 essential health services. And what I might do if I was trying to think about marketing is think about a product or service that would address each of those 10 essential health services. Price, what do we pay for them? Not only the financial value, but there may be other prices as well. There may be a social cost to us. The place, where is it located? For some services, it may be a great distance. Would that be a factor? Is it easy to get there? For people who don't have cars, is there bus transportation to get there? What are the alternatives in terms of the operating hours? Are they only open from 9 o'clock in the morning to 5 in the afternoon? If so, there may be a price for people who are paid by the hour in terms of missing work. There may even be a price if they miss work too frequently that they would lose their job. Would it be better to operate a public health service in a shopping mall rather than in an office building? I think when we talked about the mini clinics, one of their strategies is to make services available in a place that's convenient, long operating hours at a place that likely is easy to park or served by buses. Promotion. How do we convince people that it's a service they want to pursue? What are the, or why they would want to pursue it? An ongoing discussion is related to vaccination for flu. Is there value in getting a flu shot? Why would you want to get a flu shot? Those are the 4 P's if people talk about the 4 P's. The 5th P if people add it is the term people. How are the services going to be provided? In many of the mini clinics we were talking about, the service is not provided by a physician. It's offered by a nurse practitioner or a physician assistant. Is that acceptable to all patients? How many staff are required to provide the service? What's the attitude of the population, the people providing services? So you could develop a matrix like this to consider different strategies for implementation of your plan. Okay, let's talk a little about budget. As much as it may be frustrating, it's incredibly important to look at the financial aspects of the services we provide. We need to look at the resources that are available to the organization for implementation of their programs to achieve their mission. We could look at charts like this, but I think there are some things that are much more effective in communicating it. I think there are some terms you should know. Cost versus charges. What does it cost to provide a service? If we were talking about a flu shot, obviously there would be the cost of the vaccine and the syringe and needle, but we're probably talking about having a facility that's open. What's the rental for the space, the utilities for operating it. We certainly need to have running water, we need to have electricity, we need to have heat and cooling. We're going to hire personnel. What does it cost for the personnel? If we total all of those things up, that's going to tell us what the financial cost is to provide that service to an individual or a group of individuals. In contrast, when people talk about charges, what we're talking about is what the consumer is going to be asked to pay. In the case of a for-profit organization, the difference between our actual cost and the charge are the surplus revenues that would go to the investors. However, even if we're talking about a not-for-profit organization, they still require surplus revenue. If we're talking about a hospital and we're talking about x-ray equipment, eventually that x-ray equipment is going to wear out and we need to replace it. We need to have some additional money built into our budget to buy either the replacement equipment or the newer, higher technology that would be available in the future. So we're going to talk about costs and charges as part of our budget. The examples of fixed and variable costs under that cost that come to mind, again, two terms that I think are important. If you rent an apartment for the next year, once you sign a lease, you're going to be paying the same thing every month. That for the terms of your lease, your contract, it will always be the same. It's fixed. In contrast, variable costs, I drove across the country recently. I had to make a decision the first night. First, was I going to keep driving or was I going to stop in a motel? Secondly, if I was going to stop in a motel or a hotel, was I going to stop in the least expensive place I could find, or was I going to stay in something that was more luxurious? Obviously, the costs, if I choose not to stop, are going to, the variable cost is going to be zero. If I stay at the least expensive motel, it's going to be less than if I stay at a more expensive hotel. So those are variable costs. And we would want to build those into our process as well, the difference between fixed and variable costs. Okay, a couple other budget terms. Capital budget. It talks about the high-value, long-term assets. The x-ray equipment I was referring to earlier. It tends to be talking about big pieces of equipment, construction of buildings, remodeling of buildings. In contrast, we also have an operating budget, and we talk about looking at the day-to-day operation of our organization, the revenue we're generating, our expenses, whether we have a surplus or a deficit, a profit or a loss. Okay, I mentioned this one earlier when we were talking about structure. What's the difference between for-profit and not-for-profit? For-profit, those tend to be investor-owned, and the people who are engaged in those are looking for some sort of financial reward by putting money up in advance for those services. In contrast, we see many organizations, and under federal law to gain a tax exemption, it would be under Section 501c3 of the IRS code. They're defined as not-for-profit. As I said, that's different than non-profit. A not-for-profit organization has to be qualified for that purpose based upon their mission and the assurance that nobody is getting financial gain through an investment in that organization. Not-for-profits have certain benefits. They don't pay taxes. In addition to that, something that many of you have done, if you make a donation to a not-for-profit organization, you will be eligible to have a deduction on your taxes based on that contribution. That would not apply to for-profits. Third category in the lower left-hand corner is government, which would be mutually separate from the for-profit, not-for-profit organizations. So it's important to be able to differentiate between for-profit and not-for-profit. Health informatics, again, we have growing need in terms of information systems. I don't think the typical introductory course or the information in the study guides is going to lead you to have a lot of expectations related to health informatics. Perhaps the most important thing we referred to HIPAA earlier in the webinar is in regard to the confidentiality of this information. The second thing would certainly be, as I mentioned in several of the planning models, the ability to access the information for decision-making purposes. Let's talk a little bit about the workforce, human resources. There are a variety of settings that people in public health are going to be engaged in. They're going to vary from local health departments and clinical activities within those departments to educational institutions to, as I said earlier, industry. One of the interesting things that I think you need to consider is the demand for people working in public health. The associations of schools of public health tried to address the issue I mentioned earlier in regard to an aging workforce in public health. They forecast that 1 out of 3 people working in public health would likely retire because they were eligible for retirement by the year 2020. I don't think that will be the case. I think that will be in part associated with the fact that people like the jobs they do. I think a second measure may well be the fact that with an unpredictable economy in recent years, people who were eligible to retire chose to keep their jobs simply out of uncertainty related to money. But I do think that we will see people, particularly at the higher levels of organizations, retire in the near future, and there's a question of who will replace them. One of the interesting trends we're seeing right now is not only the growth in the number of MPH programs in the country, but very rapid growth in the number of undergraduate degree programs in public health. And what is the difference in knowledge and preparation between a baccalaureate public health graduate and an MPH public health graduate? So how are we going to define the education and training expectations for entry into a position? Secondly, what are the continuing education requirements once you are employed in the field? And as you probably know, once you become a CPH, there are biennial requirements for continuing education to maintain your certification. I came across this recently and I just thought it was interesting. The top 50 jobs in public health, and this website, careersinpublichealth.net, provides an extensive list. Somebody earlier talked about advocacy. Alphabetically, as you can see, the first job on the list is director of an advocacy agency. So we have a variety of positions available in public health at a variety of levels. Okay, I should stop at that one. I love my job, and I hope that you guys who are currently employed love your jobs. For those of you who are currently in MPH programs, I hope you will love the jobs you have in public health in the future. At the same time that you may love your current job, that does not preclude you from aspiring to a job with greater responsibilities. Okay, let's talk a little bit about quality or performance improvement. I suspect almost everyone who's on the webinar is likely to have a driver's license. Driver's license means a specific thing. It doesn't mean that you're qualified to drive in the Indianapolis 500. It doesn't even guarantee that all people with driver's licenses are good drivers. What it does say is that you took an examination which probably consisted of a written examination of some knowledge related to driving and in most cases a brief driving experience that showed that you meet the minimum expectations to earn a driver's license and to drive. Doesn't mean anything about high quality though. I think that the advent of the CPH credential sets the bar far higher than it ever has been in the past for credentialing of people in public health. But once again, what it's doing is setting a standard saying you've met a requirement in regard to experience in education, in regard to knowledge related to an examination, and in regard to maintenance in your profession through continuing education activities. Does it guarantee that all CPHs are excellent? I would hope it does, but I don't think that there's any assurance that it will do that. It does say that you meet a far higher standard than the average person who is not a CPH working in public health. And I think we're going to see more and more positions that are going to list CPH credential as a requirement for the job as things evolve over time. Same thing applies in hospitals. We had hospital accreditation in the United States through the Joint Commission on Accreditation of Healthcare Organizations, which was sufficiently successful that it's now moved to this level, the Joint Commission International, which talks about accreditation and certification of hospitals globally. And once again, if I was traveling and I was in another country requiring hospitalization, I would certainly select a hospital that met Joint Commission International accreditation standards over a hospital that did not have that accreditation. Okay, well, let's be more specific now. I mentioned earlier the National Academy of Science Institute of Medicine. A decade ago, they published a report to Err is Human talking about building a safer healthcare system. This was hospital specific. It did not include outpatient settings. At that time, they estimated between 44,000 and 98,000 deaths occurred annually in hospitals because of adverse events, bad decisions that were made. In addition to that, there were over 1 million injuries that occurred in hospitals. Errors in surgery, issues related to patients receiving the wrong medication, dropping babies in delivery rooms. All of those things accounted for adverse outcomes in facilities. There's no data on adverse outcomes in public health settings that I'm aware of. I'm sure that they must occasionally occur. What are we doing about that? We now have the Public Health Accreditation Board. Public Health Accreditation Board, FAB, accredits local health departments demonstrating that they meet a standard. If you go to the FAB website, this is simply the main page of their website. You can learn more about what accreditation accomplishes, eligibility, all of the requirements to seek accreditation. So we're making progress on the public health sector in regard to raising the standard both through accreditation of personnel through the National Board of Public Health Examiners and facilities through the Public Health Accreditation Board. What do we do when we're talking about quality management? A lot of people talk about this continuous improvement process consisting of Plan, Do, Check, Act. So the planning we've already talked about, the implementation, check is the evaluation, actions. We have not yet, we have not yet seen this occur in a public health agency at the national level. We have seen a number of hospitals that have achieved the Malcolm Baldrige National Healthcare Quality Award for excellence. There are state awards of this nature in many states, and there are local health departments in states such as Tennessee and Florida that have achieved They're state quality awards, which would be even a step higher than the expectations related to accreditation. And just as examples to show you the overlap, this is what Baldrige frequently refers to as the Baldrige burger because it looks a little bit like hamburger. At the top, just like all of our systems, it talks about the external environment that we work and live in. At the bottom, it talks about the ongoing requirement of measurement, analysis, and knowledge management, the information management. The two components in the center on the left and right are two triads, one consisting of management leadership, strategic planning, and a focus on patients and other customers and markets. The one on the right, looking at internal functions in terms of the staff and the human resources that it requires, process management, and organizational performance results. So at the highest level, I would say if a health department had employees who were CPH certified by the National Board, that they were FAB accredited, and they recently received the Baldrige National Quality Award for Performance Excellence, that would be an indicator of an extraordinary organization. Just going one step further, many of the courses I'm aware of talk in quality about a process called Six Sigma. And I won't go into the details on that wheel, but what I will say is that Six Sigma says we can't be perfect, but our goal would be to have no more than 3.4 defects for every million opportunities. So I don't know if it's true or not, but I was at an education session where somebody told a story about a U.S. manufacturer that wanted to use ball bearings, little metal steel balls that were manufactured in Japan. And they contacted a company, and in the contract they specified that they wanted to purchase 10 million ball bearings, and as part of that, under Six Sigma, no more than 3.4 defects per million. And the story goes that they received a letter with an envelope in the mail, which said, that to the purchasing officer, please be advised that your 10 million ball bearings are being shipped on the following way, and you should receive them by the following date. However, the 34 defective ball bearings you requested are enclosed with this letter. We would like to inquire and ask you to respond and advise us why you have requested the 34 defective ball bearings. As I said, I don't know if that's an indicator of high quality with the manufacturer or if it's even true. But think about it, 3.4 per million sounds very good. If we were talking about delivering babies in hospitals and we said that we're going to set that standard and only 3.4 babies would be dropped, let's round it down to 3. We would only drop 3 babies in delivery rooms during their births out of every million births that took place. We would consider that unacceptable. If we were talking about dispensing medications in hospitals and we talked about 3.4 errors in dispensing medications for every million opportunities, again, that would concern us, but as the Institute of Medicine reported, we do see numerous adverse outcomes occurring in hospitals. At this stage, we do not have good data in regard to defects in the provision of services in health departments. I think that will be coming in the future, particularly with the advent of the FAB accreditation process. Okay, so just in closing, pictures of Arnold Schwarzenegger. I think that this is an ongoing commitment. We all exercise. We all get lax about our exercise. So let me ask any management questions at this stage. Kate, any questions?
1 second, let me just check real quick. No, there are not.
Great. Okay, I suspect people are getting fatigued at this point. We're almost finished. Let me see if I can link up again. Okay, so as I said, we're almost finished. What I've tried to do as part of this session is recap what I think would typically be in the course that the current examination is based on. I don't know, in Dr. Peterson's session, she may have talked about the evolution of the exam over time. There's going to be a job task analysis, which becomes the basis for the examination in the future. At the present, what we're talking about is aligning it with this set of 10 competencies, along with the content outline. And I've tried to cover as many things as I think might be common to the courses that address those topics. Let's go back to our questions, and then I'll show you some resources that you may want to use if you want to look at anything in more detail. Our first question in regard to being awarded certification in public health from the NBPHE. Is that structure, environment, process, or outcome? The award is an outcome. I revised this question. I think my headset battery is getting low, so I'm going to switch over. Can you still hear me? Okay, am I still here?
I can still hear you.
Great. My headset started beeping, and I didn't want to lose things. Great. It's an outcome. If that question had been phrased differently as taking the examination consisting of 200 questions, the answer might have been process. If you said that the bylaws of the national board specify an examination to become certified, it might then become a structure. So that one can be a little bit confusing. Read it carefully and look at those three levels. The smallest percentage of the healthcare, U.S. healthcare spending addresses public health services. As I noted, the most recent data I have is less than 1%. Policy, potential injury to research participants. The Belmont report refers to that as beneficence. U.S. Constitution empowers detention of contagious individuals. It's not explicit to detention in the Constitution. It's statutory authority based upon the Constitution. Delivery systems paying a monthly flat fee for all medical care reflects the nature of a health maintenance organization. Shriners Hospital, non-sectarian, it's a not-for-profit, non-religious facility. By February 1st, 2017, there will be a 0.2% reduction in HIV infections as an example of an objective. It's very short term, it's a very small increment. If we were talking about by February 1st, 2020, there will be a 10% reduction. In more likelihood, that would be a goal. Budgeting for the recurring monthly restocking of flu vaccine would be a fixed cost. We know exactly how many. If it said budgeting for the recurring restocking of flu vaccine based upon demand each month, it would be variable because we wouldn't know how many doses we would buy next month versus the month after that. Okay, let me talk real briefly about a few more resources, then I'll give you an opportunity for any additional questions you might have. In regard to the public health structure and systems, I think these two books, Scutchfield and Keck's Principles of Public Health Practice or Essentials of Public Health, might be excellent books or would be excellent books for review. Some of you may have taken an MPH course which used one of these books. In regard to policy, I would recommend the following two books, Health Policy Making in the United States and Essentials of Health Policy and Law. And in regard to management, Managing Health Services Organization and Systems, and Essentials of Management and Leadership in Public Health. I failed to mention in each of these 3 cases, the book on the left is a very detailed book, probably 400 pages or more. The book on the right is a much more concise book. They were really designed more for an overview of the content, even at the undergraduate level. Okay, so in closing, I'd be happy to entertain any questions you might still have. I hope you all are very successful in the examination and you become certified. I think I just lost control for a second. Okay, so that wraps things up. Kate, do you have any wrap-up comments before I ask if there are any final questions?
Joel, I don't see any questions. So with that being said, if you have nothing more to say, I can close the session.
Great. One thing I can think of, availability of my slides for anybody who'd like to have those.
Yes, slides will be available on the MBPHE website.
Great. Well, once again, I wish everybody success with the exam. I think this is an incredibly important thing to assist in professionalizing careers in public health, and I wish you well. And Kate, thank you so much for your help.
Thank you so much, Joel, and thank you to everybody who participated today in the National Board of Public Health Examiners presenting the 4th in our series of 6 webinars geared to explaining the domain areas of public health to help you prepare for the upcoming CPH examination. As we mentioned, these webinars are recorded and placed on the MBPHE website for future viewing, so within 1 to 2 days you should be able to see this webinar on the website. And please be sure to register for the remaining webinar on biostatistics on the MBPHE website. Any questions can be sent to info@mbphe.org. And thank you again. Thank you, Joel. And everybody, good luck with the exam and have a great evening. Thank you again.
Bye.